First, it's a pleasure to come and speak again, and it's wonderful to see the room filled with people, and I've met a few new members of AAPS, and talking with those few new members, it's about time that you joined us. So welcome. So in keeping with all medical talks, I have nothing relevant to this talk to disclose. So it is up to us. I'm going to ask you, what if they gave a health care plan and nobody showed? I'll tell you also, I'm not a politician, nor is this a comment on computers. Talking about myself politically a little bit, looking at the political spectrum over here on the far left, we have two notable figures, and on the right, also two notable figures. And you figure that McCain is somewhere around there, which is probably about where I sit on the political spectrum. But this is one of my favorite cartoons also. And not that I suggest that Mr. Obama would actually wield the baseball bat, but certainly anybody who has objected to Obamacare. We're now allowed to call it Obamacare because he calls it that himself. I think we should start calling it Obamacare less, but that's a different question. So certainly anyone has been beaten up if you dare voice objection to the rules. So what we need to do in this country, though, is avoid this. You know, Cash for Clunkers Healthcare Edition. So I'm going to start in this talk by asking, what is your motivation for medicine? Is it money? Is it lifestyle? Local recognition? Satisfaction in a job well done? I'm going to talk a little bit about a frame of reference here. Are people familiar with the story of Sammy the Shirt Maker? No? Okay. Sammy the Shirt Maker, been in business for many, many years, but as time went on, his costs went up and the rent went up, and he needed to hire more employees, and he needed accountants and other sorts of stuff. And his accountant came in and said, you know, Sammy, you got to raise your prices. You're losing $1 on every shirt that you sell. And his comment was, I'm not concerned, I'll make it up in volume. You really can't do that in medicine. I refuse to be the assembly line physician, and I hope that I'm speaking to like-minded people here. Because productivity has limits. You can't get a symphony orchestra to be more productive by asking them to play faster. Okay? I'm also going to talk a frame of reference here. You're familiar with the myth of the frog in the frying pan. Now, I've never actually tested this. I don't know if anybody has, but the theory is that if you throw a frog into a hot frying pan, it'll hop out unharmed. But if you put it into a cold frying pan and turn the heat up slow enough, it will eventually be dinner. So this man, Trent Lott, many years ago, Dr. Bill Robb from the American Association of Hip and Knee Surgeons was with a bunch of other doctors, and they lobbied Trent Lott about the cuts in Medicare fees. So he was a former Senate Majority Leader, and he was lobbied. And his comment to them was, how many of you take Medicare now? And in that group of doctors, they all accepted Medicare. So his comment to them was, come back when you quit taking what we give you. To 2006, Congressional Budget Office, 90% of physicians and non-physician providers agree to accept Medicare. Right? Talking about the SGR mechanism. But there was concern that if the SGR mechanism continued, it may change. People may not be willing to accept it any longer. And it said here, 2006, right? It's uncertain at what point such responses to declining payment rates would have a significant negative effect on Medicare patients' access to physician services. So in short, they're counting on all of us being frogs. Okay? Come back when you quit taking whatever we give you. So I'm suggesting that you don't try to be Sammy the Shirt Maker. You'll go broke. Don't be a frog. You will be sautéed. So my goal today for any of you who do accept Medicare at the present time is to convince you to opt out. Let's take a look at a few things that Medicare is doing in the private sector. The private insurance companies are following suit. Consulting fees. A physician sends you a patient. It's a consult. It's billed at a higher rate, only it doesn't exist any longer. So if you this is the per visit loss of money for a new patient examination versus a consult from another physician. So if you look at that over a year, for example, if you did 10 consults per week and you billed a level 4 exam, at the end of a year, that's $45,000 off the top. Now, in orthopedics, most orthopedists have an overhead that's about 50%. So if you take $45,000 off the top in an orthopedic practice, you've taken $90,000 out of the doctor's pocket. Okay? And there are regulations, even before Obamacare, 130,000 pages of regulations concerning how we practice medicine, 11,000 specific to physicians' practices. And this is before the current health care law. God knows how many there are now. But the government, of course, doesn't practice medicine, or at least they insist that they don't. My specialty, again, is hip and knee replacement, but let's look at what they're doing now in regard to hip and knee replacement. After you've done a hip or knee replacement on a patient in the hospital, they'll review the chart. And after the fact, now these are on average, by the way, high school graduates doing the review. Okay? High school. At least they graduated. So they will then review the hospital chart and decide if there's been enough non-operative treatment to constitute failure of non-operative management. And they'll look for example, what anti-inflammatory were they on, starting on what date and lasting until what date. Not 3 months of anti-inflammatory therapy. They want to know starting April 2nd and running through August 3rd. Right? Dates and number of times of physical therapy sessions. Specific discussions about diet and weight loss and dates and pounds they might have lost. Now then, if the surgery is deemed appropriate, it is appropriate, but otherwise it's deemed unnecessary. And I've seen some of these letters. The patient shouldn't have been in the hospital because they did so well. And therefore the hospital is not going to get paid. And further, the hospital can't bill the patient for the difference. Nobody gets paid. And so there really is not any good guidance as to what is appropriate at the present time, because of course that would be practicing medicine. And again, this is only after the fact. This is only one example, because there really is an alphabet soup of groups that are out to audit us and to decide whether or not what we do is appropriate, and very few, if any of them, have the training to make that distinction. And many of them, particularly the recoupment auditing contractors, have a benefit if they find something wrong. They get paid. They get a fraction of whatever fine you have to pay. They get some of it. And there's some proposed rules at the present time where they can look back 10 years. I've been on electronic medical records, but we had a problem before 2006. I don't know that I have records. So if someone came and looked back at my practice 10 years, I couldn't say that no. I couldn't prove them wrong because I don't know that I have the access. I'd have to assume that they have the right information. So the penalties are and can be quite severe. The False Claims Act, of course, up to 5 years jail time, $25,000. And if you read through Obamacare, there are lists of levels of penalties, and there are 4 levels. And by the way, the penalty for the 4th level is limited to $1.5 million per year. Now, the first level of problems that you can have, and they can find fault for you under Obamacare, is an honest mistake, something that, you wouldn't have been expected to know it. That's supposedly the lowest level, but it's really limited by the highest level. It's got to be at least the lowest level, but limited to $1.5 million per year. That becomes a problem. And we've already heard about James Natale. He's a gentleman on the left here. And while I don't condone the idea of dictating your operative reports weeks down the line, that's not necessarily good medicine, but it's not a federal crime. So people, the ZPIC people will be profiling your practice, and if you build more of a higher level of service than your community, even if you legitimately do a better exam, you've now invited the government in for a friendly review of your charts. On the other hand, if you do no government billing, effectively you disappear. I'm going to give you a quick example here. These are two different evaluations. On the left here is a basic exam that doesn't say an awful lot. Patient has a swollen knee. They came to me with knee pain. I submit this exam, I can bill a level 4. It hits enough points under the current system to bill a level 4. The exam on the right, though, if you look at that, that's a very detailed examination of a knee. It barely qualifies for a level 2. So is there justice? I bring up these two pictures of Lady Justice because many of us think about Lady Justice on the left as being blind. But traditionally, actually, Lady Justice is not blind. There is no blindfold, and her sword is out, ready to be used. So the odds are very heavily stacked against the physician in any audit. You may remember a few years ago we had pay for performance. Initially, it was a way to earn a couple of extra dollars if you met all the metrics. Only a handful of issues for each specialty. And generally, the things that they were asking us to report on were things that were done anyway, that we would do or we should do anyway. But less than 60% of the doctors who tried to gain these extra dollars actually earned them. Here's what pay for performance, one metric that falls into my field is perioperative antibiotics. I need to collect and report on every patient all of these parameters. And failure to document all of these parameters, the time of administration of the antibiotic, for example, on 98% of the patients, I would not meet the metric and would not get the reimbursement. I didn't think that it was worth the time or the energy or the money. But of course, pay for performance has now become penalties for lack of paperwork. Right? And I do have an electronic medical record, and it pops up the list of things that should be completed in order to comply with all of the metrics relevant to my practice in orthopedics. On a pre-op visit, here's the list. Right? Inquiry regarding tobacco use, colorectal cancer screening. These are patients having elective orthopedic surgery. Does this have any relevance? But there's also a move now that if you start recording this stuff and billing a higher level because of it, it's not relevant to what you did. So we're caught both directions. Of course, you know, the Committee on Comparative Effectiveness Research, now the IPAB, started with $1 billion and it's $350 million annual budget and defines meaningful use of electronic medical records, which means that you will turn over to the Secretary of Health and Human Services anything that he or she requests that you do. And there are zero limits, I should say there's one limit on what the Secretary of Health and Human Services can demand that you collect. How the NRA got involved in this, I don't know, but they are not allowed to command physicians to collect information on legal gun ownership. That's the only limitation on what the Secretary of Health and Human Services may demand of physicians who try to make meaningful use out of electronic records. So this is the end of privacy. The physician-patient relationship should be sacrosanct. People tell us things they don't sometimes tell their spouses. It shouldn't leave the examining room. But the Secretary of Health and Human Services and Congress, of course, is exempt from HIPAA regulations. So it also, I think in January of 2015, if I understand the law correctly, will mean the end of opinions. Because on that day, private insurance companies also may only contract with doctors who comply with meaningful use and the supposed quality improvements that are involved in Obamacare. And of course, this is not subject to administrative or judicial review. And I only know of one person in any political system that is not subject to administrative or judicial review, and those are generally called dictators. So if you don't comply, of course, you don't go to meaningful use of electronic medical records, they can fine you. And I hope, it is my hope, that by not accepting their money, they can't fine you. We've already heard a little bit about the Justice Department declaring war on doctors. This was an Idaho case where the government stepped in and sued a group of doctors because the group of doctors refused to accept a private insurance company fee schedule because that fee schedule is based on Medicare. I mean, does that make any sense at all? It makes no sense whatsoever. So there are two types of doctors. Okay. Medicare doctors are, to Medicare, they are compliant doctors who do all the paperwork, and we are interchangeable. I'm sorry, I don't consider myself interchangeable, and I would hope that you do not consider yourself interchangeable as well. Anybody else is considered a bad doctor. Now, the ACE program is a pilot program that's going on in San Antonio and 4 other places around the country in orthopedics and in cardiovascular surgery, where there's another step to it. There are compliant doctors who are interchangeable, and there are expensive doctors who are bad. So do you really still want to deal with these folks? So what can you do about it? Okay, let me out, set me free, opting out. I want to talk a little bit about what my experience was like. I opted out in July 1st of 2008. Now, I'm an adult reconstructive surgeon. Who are my patients? These are old people with old joints. So what happened in 2008? The economy crashed 5 months later. I found my volume is down. My billing is now not limited by some of the Medicare rules. And this is a graph of patient visits. You'll see that just under half of my patients, not counting HMOs, were straight up Medicare before that, and this is patient visits. And I've retained a large portion of that. About a third of my patient visits, total visits, are still Medicare patients. More telling, though, is this graph here. If you look at the blue line that's the highest on the left side, that's Medicare collections. And you see that drops to almost nothing after 2008. And the yellow line is private fee-for-service, people willing to pay an honest fee or reasonable fee for good service. And if you look at the overall effect of this, you see that since 2008, the income has been steadily increasing. But there's one more aspect to that. Now, the scales are a little different so that you can still see the differences. But the bar on the left in each pair is the total number of patient visits, with the top of the scale being about 4,000 visits per year. And the green bar is the number of surgeries, with the top of the scale being about 600 surgeries per year. So while I'm less busy, spending more time with the patients, income has gone up. It gets better. I had a physician assistant when I was on Medicare, and indicated by the red line here, and you can see something very interesting. Early on, before we got this physician assistant on all of the insurance panels, we started collecting money. After a couple of months, she was on all the panels. The money goes way down. That little uptick at the end happened to be Aetna, where she had not yet been approved, and we had done a fair number of Aetna cases. So overall, I lost money in a year and a half of her work. Second physician assistant did not sign up for any insurance companies. And you see, not only is he doing very well, but I keep a small portion of that as well. So the overall story here, I've won. What's in the victory? More time with my family, more time with the patients, a positive change in the income, fewer headaches, and less caffeine. Okay, so how do you do it? First of all, preparation. Be able to articulate why you are opting out. Understand and know the legal requirements, and the AAPS is a wonderful source for all of that information. And also understand the difference between a non-par and an opted-out physician, because very few people understand that, and odds are in your community, secondary insurances don't understand that also. And send out good letters to patients and colleagues. Send out good letters. What sets you aside from the colleagues in your community? Do you get better results? Do you spend more time with the patients? Find something that's of value to the patients or the consumer here of your services. Don't blame the money or the cuts. You sound like the AMA, because it only makes you look greedy. But prepare your staff too. Make sure that they understand. A lot of them will not understand this easily. Make sure that they understand the whole picture and can communicate it. Write scripts for your patients. Have it posted by the phones. Dr. X is happy to see Medicare patients, but you don't accept Medicare as insurance. So also remember, this is something that I've taught my staff over and over again. It doesn't matter what you say, it matters what people hear. So if people don't hear something the way that you've said it, think about how you've said it. Because everybody must understand what this is about. that the idea that you don't accept Medicare as insurance is not the same as I don't want to see Medicare patients. I love seeing new Medicare patients. They're the basis of the practice. And so do role-playing with your staff. Do some of it yourself. And prepare your patients. Take the time to talk to them before you go off. The line I use with them, you're still part of the family, we'll continue to take care of you. And if you do it right, many, if not most of your patients will stay with you. And now that you're off Medicare, it's legal to negotiate prices and payment plans. And I think most people will think that you get paid a whole lot more than you do. I'll give you the example. When people were asking how much do I charge for hip or knee replacement, the lowest guess that they would come up with was 5 times what I actually decided to charge. And I decided to charge about 3 times what Medicare would pay. Okay? One person estimated 20 times what I charge. Tell you, if I really collected that sort of money, my waiting area would be marble. We'd be serving champagne and caviar and apologizing for the wait, you know. Okay. Also, people will think that because you're off Medicare, nothing will be paid by Medicare. That's not been my experience. 4.5 years I've been off Medicare. They pay for everything except me. One of the things that's very nice now, the recoupment auditing contractors can't come into my office. I've been off more than 3 years. They come into my office, I call security, have them escorted out. And this actually is very reassuring to the patients because they don't want their charts audited by the government. They consider this information private too. But also take one comment that was made when I was in your seats, and there was another doctor up here talking about his experience getting off Medicare. It won't be long, most likely, before income is replaced by patients on a cash basis. But make some preparations. Find a few other alternate avenues for income, whether it's involving yourself in clinical studies, legal review or testimony. You know, maybe spend a little time on the dark side with the insurance companies. And prepare your family. They will see more of you, and you'll generally be in a better mood. And I think this is really telling here. Most patients think that you're worth a lot more than you think you're worth, and many times what the government thinks you're worth. And even in tough economic times, there are enough people willing to pay a reasonable price for good service. Thank you very much.